Hello, I'm Dr. Therese Johnston, and in this session, I'm going to talk about decision making for outcome measures when applying some recommendations from a clinical practice guideline. And I'd like to acknowledge my co-author on this CPG, Dr. Lisa Brown from Boston University, who is instrumental in this work and this presentation. The clinical practice guideline that we developed was on the use of ankle-foot orthoses and functional electrical stimulation post-stroke. And this was published in the Journal of Neurologic Physical Therapy in April of 21. And I'd like to acknowledge my co-authors on this project. So in addition to me and Dr. Lisa Brown, Dr. Sarah Keller and Dr. Caitlin Denzer-Weiler were co-authors on this piece of work. So looking at the action statements that were developed for the CPG, we decided to categorize the different outcomes based on the ICF. And so you can see across the top of the screen are the participation, activity, and body structure and function categories. And I also want to point you to the stoplight here. We have the green, yellow, and the red. So green represents a strong action statement. So we're saying we should do something. So we should be using AFO or FES to address that particular outcome. Yellow gets into the may, and then red gets into the should not. So in looking at some of these, we first looked at participation. And in participation, we looked at quality of life. And what we found from the evidence is that we should be using AFO or FES to improve quality of life. And the C in parentheses represents that this statement was made for people with chronic stroke, not acute stroke, since quality of life is more challenging to assess in somebody with an acute stroke. And now looking at our activity category, here you can see that we have should statements for gait speed, mobility, and dynamic balance. And looking at endurance, we have a should statement for people with chronic stroke, but a may statement for people with acute stroke. And this is mainly due to the amount of evidence available and the quality of that evidence. Now looking at body structure and function, we'll go through each of these individually. So for muscle activation, we had different recommendations for FES and AFO. We had a should statement for FES, but a may statement for AFO, again, just based on the state of the evidence. For gait kinematics, we had a may statement for providing AFO or FES. And for spasticity, we actually had a should not. And the should not in this case represents that we should not be prescribing an AFO or FES for the sole purpose of decreasing spasticity. We may, however, be providing this for other reasons, as in these other categories. So when linking the level of evidence and the grades is represented in this table. So this is what we used in developing the level of evidence as well as the word that was chosen for each of the action statements. So if we start in this first row, we have a level of evidence of 1, which represents a strong preponderance of benefit or harm. And from this, we can choose a must or a should statement depending on the state of the outcomes. And here we can give this an A or a strong recommendation. So if we scroll down to number 4, so level of evidence 4, this would be where we have weaker evidence for preponderance of benefit or harm. And here's where we choose our may statement. And some of the differentiating factors here is that 1, we tend to have more randomized control trials, where 4, we often are finding that there's no more cohort type of studies. So the outcome measures component was a very important piece in our clinical practice guideline. When we initially looked at the evidence, we decided that focusing on specific outcomes was the best way to proceed in developing our clinical practice guideline. And outcome measures are going to be the best at providing us that measure of the effectiveness of the intervention because they're very objective. And they also support evidence-based practice, which is very important. Outcome measures also can help to inform our patient-centered healthcare decisions. And then at a higher level, the outcome measures can influence funding and policy decisions, which are important for overall care of our patients. So looking at the outcome measures identified in the CPG, I'm here presenting just the ones for participation and activity to show you what some of the primary measures were, as well as some of the secondary measures that were used in the studies that were included in the clinical practice guideline. So first, looking at quality of life. So here we have two outcome measures that are specific to the populations of stroke. And then one that is a little more general, the sickness impact profile. So these were the three that were most commonly used in the studies. When we look at some secondary measures, here we see that some of these were more global measures of quality of life, so less disease specific. And looking at gait speed, the majority of studies use the 10-meter walk test. But you can see in the secondary measures box that there were quite a variety of distances used for people who did not use the 10-meter walk test, but still all of them did use a shorter distance walkway. When we look at the category of other mobility, the primary measures were the functional ambulation category and the modified Emery functional ambulation profile. So these measures include a variety of different activities that the person needs to perform. And secondarily, we saw the use of the functional independence measure. And looking at dynamic balance, the Berg balance scale, the timed up and go, and the timed up and down stairs were the most common ones that we saw in the literature. Some of the secondary measures, the figure of 8 test, the activity-specific balance confidence scale, functional reach, and falls efficacy scale were used. And then looking at endurance, the 6-minute walk test and the physiological cost index were the measures that we saw. And looking at this table, you can see I have several of these measures italicized. And these are italicized because these are outcome measures that are recommended by the core set of outcome measures for adults with neurological conditions by Moore et al. In this next section, I'm going to highlight the use of the recommendations from the CPG for a specific patient case. So in this case, it was a 76-year-old person who had left hemiparesis from a stroke approximately 1 year earlier. You can see the past medical history here that is pretty common for people with a diagnosis of stroke. This person enjoys gardening, caring for grandchildren, but is also reported falling twice while walking in the garden. And most importantly, we want to focus here on the goals of the patient, because these are going to guide our interventions as well as the outcome measures that we are going to choose in deciding on an AFO or FES for this person. So this person wanted to improve safety during gait, especially when walking in the garden due to those falls. This patient also wanted to improve capacity for walking in the community, so getting across the street safely, navigating various surfaces. And this patient also wanted to increase involvement in the community. So we can take each of these goals and look at them in terms of the action statements in the CPG, as well as the outcome measures that were used and thus recommended for each specific outcome. So we look at goal number 1, which the patient would like to improve participation in social and community activities. So we can look at action statement 1 at quality of life. And looking at our key outcome measures, we can choose one that's specific to stroke or the sickness impact profile. And the choice of these may depend on the patient's specific goals. So looking at the questions in each scale to determine what might be the best for that person. The second goal is to improve speed of walking. So here we can look at action statement 2 on gait speed with the 10-meter walk test. And then the third goal, to improve balance and decrease falls risk, we can look at action statement 4, which is dynamic balance. And here we have a variety of different measures that we can use to assess balance. Again, we can select these based on the specific needs of the person. So looking at each of these individually, first we'll look at action statement 1 on quality of life. And the action statement for This outcome is that clinicians should provide an AFO or FES for people with chronic post-stroke hemiplegia. And looking at the quality of the evidence, it was level 2 overall when looking at all of the studies together that reported on quality of life. And our recommendation strength here was moderate, but we give this a green light and can move forward with this action statement. So in looking specifically at the patient goals, we first look at the person wants to be able to improve their social participation. So we can choose that outcome measure. And as I mentioned, we're going to choose that based on the specific needs of the individual. And one thing that's interesting in terms of quality of life that we found in the literature is that user satisfaction has been shown to be higher in FES users compared to AFO users. So this is something we can keep in mind as we're making decisions for this patient in terms of what device might be the most appropriate. Now moving on to gait speed. So here again, we have a should statement that we should provide an AFO or FES for people with chronic post-stroke hemiplegia. And here we had really strong evidence. Level 1, we had more RCTs that looked at gait speed. So this is a strong one to move forward with. So again, the patient's goal was to be able to walk faster and farther in the community. So the outcome measure here is our 10-meter walk test. And this patient, for the comfortable gait speed, had a gait speed of 0.40 meters per second. So this person is walking at a slower gait speed. So that's something to keep in mind in terms of how we're choosing a device for this person. Now moving on to dynamic balance. Again, we have a should statement for AFO or FES in people with chronic stroke. And again, we had really strong level 1 evidence for this action statement, so we can proceed. So again, this person's goal was to improve confidence and safety with dynamic gait, especially when outdoors and in the community. And so we can look at these specific outcome measures and choose which ones we think are most appropriate for this patient. For this patient, we chose to look at the TUG and the BERG. And with the TUG, the patient completed this in an extended period of time that suggests a falls risk, as well as the BERG also is suggesting a falls risk. So this is something we need to keep in mind for this patient in choosing a device, because this person is at increased risk of fall. All right, and looking at the outcomes in relation to specific designs for AFO or for FES, there are some considerations that we should keep in mind. So for gait speed, an important part of gait speed is getting propulsion. So any AFO design that's going to limit the ability to achieve plantar flexion range of motion for push-off and propulsion, or limits plantar flexion muscle activation, will have limited effects on gait speed. So we need to keep this in mind, because one of the patient's big goals is gait speed. One thing that's nice about if we can improve gait speed with the appropriate AFO design, this can help to enhance the impact on other outcomes. So improvements with this AFO can also improve balance, endurance, and quality of life. And then we can also look at some information from the literature showed a combined effect reporting improvement. So combined effect is an effect after the person's been training with a device for a period of time. And what's been found in the literature, the gait speed improves both with AFO and FES, often exceeding what's the small meaningful change or the minimally clinically important difference for that 10-meter walk test. Now looking at dynamic balance, one component that's very important is sagittal plane motion. An AFO that allows sagittal plane motion is going to be more effective at improving dynamic balance, while an AFO that restricts motion may be more effective for static balance. So we need to relate that back to the patient goals. And in this case, the patient was more concerned about dynamic balance. FES has been shown to potentially be more effective in improving that reactive dynamic balance. And I mentioned earlier about where we need to choose the outcome measures that best match what the patient goals are. Here, this patient's interest was in dynamic gait. So outcome measures such as the FGA and the TUG may be better choices for this person. All right, we can look now at the overall plan of care and putting all of this together. So we look at our patient preferences, so the goals, the expectations, as well as those considerations that are personal and environmental. The next step in deciding how we're going to proceed with an AFO or FES is to do a movement analysis and also assess the appropriate outcome measures, which we showed for this person. Then we can trial different devices. We can look at different designs of AFO that may meet the goals as well as FES. We also need to think of some of the benefits, the risks, and the harms. If we provide a device that the patient doesn't like, it's going to be abandoned. And so we need to really consider the patient's perspective in this decision making. We also need to think about cost and insurance coverage because not everything is covered by insurance. And we also need to determine the impact on falls risk because it's important that we choose devices that are going to meet the safety needs of the individual. All right, so putting this all together for this particular patient, this person was trialed with an articulating AFO as well as a posterior leaf spring and with FES. So looking at that top box on the left, the impact on gait speed and dynamic balance, we saw there was an immediate increase across devices with somewhat of improvement in the 10-meter walk test with an articulating AFO, but a slight decrease with the posterior leaf spring and the FES. And this immediate effect is really just when the person tries this the first time. So this is without any training. So this is just that immediate effect. And we look at balance using the Berg. We saw an improvement with the articulating outperforming the other two options, but we also saw a decrease in the tug. And so something to keep in mind, again, that immediate effect, and we need a period of training and skilled PT interventions to be able to maximize the outcomes with these devices. Looking over on the right side now, we can look at the preferences of the patient. So she felt the most stable in the articulating, but also felt somewhat restricted. The FES was tolerated well, but the patient was interested in having more practice with the device before making a decision. All right, moving down to the benefits and harms. With the articulating AFO, we're more likely to have greater effect on the falls risks. We would need training with all of the devices. It may take longer with FES. The literature shows added training is needed, longer periods of training before we can truly assess the outcomes of that device. Skin issues are always a concern when we're putting anything on the person's skin. So whether it's the FES or the AFO, we need to think about the benefits and harms of the skin. And then we also need to think about the insurance coverage, which is more consistent with AFO than with FES. And then finally, we can go over to the shared decision making. And along with the patient, this decision was made to choose the articulating AFO. And the patient was provided with education about the cost, the maintenance, the benefits and harms related to this choice. And the final decision was made after going through a period of skilled PT intervention. The patient felt this was the best choice to meet the goals. All right, to summarize, clinical practice guidelines provide those evidence-based recommendations that can inform our decision-making, reduce variability in practice, and optimize the outcomes for our patients. And using outcome measures is necessary to assess the impact and effectiveness in the interventions and to drive that improved quality of care. And these measures are going to be most effective when they match the desired outcome interest. So it's really important to make sure they match the patient goals and the desired impact of the specific device. And shared decision-making is very important. We need to empower our patients so that they are fully participating in healthcare decisions. We can discuss evidence with them, go through the benefits of harms, and we have to make sure that what we choose is in alignment with the patient's values and preferences. In this last slide, I just want to point out some knowledge translation resources that are available through the Academy of Neurologic Physical Therapy. The link is at the bottom of the page here. So on this site, you will find a link to the clinical practice guideline itself, which is a free publication for anyone. And then there are also knowledge translation resources that you can click on and download. Most of these are designed for clinicians, so they synthesize some of the information from the CPG, provide some one-page documents that could be really helpful. There's also a document that is geared towards people post-stroke who might be interested in AFO or FES. And thank you for your time.